Alrighty, so we just finished our second procedure of the day. So what we did today for this gentleman was he was in an accident in early February, which caused some neck pain, some radicular pain, and then a little bit of burning and paresthesias in and around the thoracic cervical spine, and then also down into his arms. Now he has worked with a few other providers, some physical therapists. He's had dry needling. He's had other treatments done, and has been in really good hands. And most of the central cord symptoms that he is having have resolved, and so he's no longer having a ton of radiating pain down into the arms or anything like that. But he is still having some symptoms, especially when he's in a slight cervical flexion position. And so we reviewed his MRI, which showed some mild central stenosis, which on its own is probably not causing a huge amount of symptoms in that neutral position. But because when he goes into flexion, basically the ventral or the front side of the spinal cord is going to get compressed a little bit because of the disc bulges that he has in the cervical spine. And so our approach today, this is phase 1 of 2, and hopefully we don't have to move to phase 2. But phase 1 is basically today we performed a cervical erector spinae plane hydrodissection. And so we went up to the transverse process of C7 and then injected deep to the erector spinae muscle group in order to try to bathe the dorsal root ganglia and the medial cutaneous branches in that region to try and just calm down some of that nerve inflammation. And then the structural component that we're going to work on is improving the posterior stability of the spine such that we get more of that C shape, so our cervical lordosis, as opposed to the loss of cervical lordosis where it flattens out. And so a lot of that is, all that stability comes from the capsular ligaments in the back of the neck, so around the facet joints. We have the nuchal ligament, and then all the little stabilizing muscles, so that things like the multifidi, as well as some of these suboccipital muscles. Now, we also treated his suboccipital muscles up on the suboccipital ridge, and my thinking behind that is when we have dysfunction in those muscles, what can happen is you can actually get a small minor collapse of the dura up at that level, because there are actual fascial attachments from the suboccipital muscles down to the dura. And so if those muscles are not functioning the way that they should, they are not firing appropriately, their tonicity, either they're locked long or locked short depending on what's going on, what we can have is we don't get as much tenting of the dura in the upper cervical region. And so because with him we are trying to improve how much fluid flow we are getting in the CSF, so that way the spinal cord has nutrition and we're not having any of that compression from the central stenosis. That is our goal and our approach there. And so we're going to track him over the next week, and then potentially next week we will do phase 2 of our treatment, which may include an epidural, it may include nerve root hydrodissections, or it may just be an erector spinae plane hydrodissection. We don't know yet. We are going to base that determination on how he does this week prior to next Friday. So that is our second case of the day. I think that's all we have left for the day here, so I'm going to get to some food, but I hope you all enjoyed watching this week, and like, comment, subscribe. Let me know what you liked, and we'll see you later.